I will now be discussing fractures of the tibia to the foot. These are my disclosures. Tibia shaft fractures are relatively common injuries in orthopedic trauma. Patients usually sustain these injuries secondary to high energy trauma. However, low energy mechanisms and stress mechanisms have also been described. Usually a patient will present with pain and the inability to ambulate. There is often limb deformity, which requires realignment. It is critical when pulses are absent to assess vascular status. This is usually accomplished with ankle brachial indices. Open fractures should be assessed and investigated. These will require operative debridement. The classification is usually descriptive, but the OTA type 4-2 is used as well. The 4-2A is a simple fracture. 4-2B is a butterfly or wedge fragment, and the 4-2C is the comminuted tibial shaft fracture. Soft tissues are described also with an OTA classification, but more commonly with the Castillo classification, with type 1s being minimal soft tissue injury less than 1 centimeter in length and low energy, type 2 an intermediate fracture between 1 and 10 centimeters of varying degree of soft tissue stripping, and type 3, the most severe, being greater than 10 centimeters in length and severe disruption of the surrounding soft tissues. The type 3s are subdivided into A's, B's, and C's. The A's are closable or coverable with a skin graft. Type B requires a soft tissue flap, and type C require vascular repair. The mangled extremity is a separate topic, best described with the LEAP paper, Lower Extremity Assessment Project. The key takeaways from this multi-center study was that no extremity index was able to predict outcome. An insensate limb is not an indication for immediate amputation in severe mangled extremities. And finally, at 2 years, outcomes are similar for those who underwent early amputation and those who underwent limb salvage. Compartment syndrome occurs following tibial shaft fractures anywhere from 2 to 6% of the time. There's no difference between incidence in open and closed tibial fractures. Implants do not make a difference in the development of compartment syndrome, and the most common mechanism leading to compartment syndrome is that of pedestrian struck. Low energy fractures, spiral distal fractures, different level fibula fractures may be treated non-operatively. This is based on discussion between the surgeon and patient. Usually it involves functional bracing and weight bearing is tolerated, and the literature talks about maximal shortening of 1.2 centimeters. Patients are initially treated in a log leg cast, which is then converted to a patella tendon bearing cast or brace. Sarmiento's outcomes are reported here with an average 4 millimeters of shortening, angulation less than 6 degrees in either plane, and only a 1% non-union rate. Obviously, these results have been difficult to reproduce in the years since. The intact fibula presents a special situation in which if there is a transverse or short oblique fracture and an intact fibula, this has been associated with a 25% of non or malunion rate. Unstable tibial shaft fractures are defined as those with severe soft tissue injury, i.e. open fractures, or severe blistering, those with articular surface involvement either proximally or distally, those with greater than 100% initial fracture displacement or bony comminution of greater than 50% circumference of the bone, transverse fracture patterns, and those with an associated fibula fracture at the same level. These are less apt to be able to be treated non-operatively. When treating a tibial shaft fracture operatively, a number of implants are available to the treating surgeon. External fixation has historically been used when there is severe soft tissue compromise and as a temporizing agent in a damage control situation. There are a number of types of external fixators, including uniplanar, multiplanar, and circular frames. Pins can either be 5 and 6 millimeter half pins or thin transfixion wires placed under tension. Plates and screws are also used for tibial fractures. The majority of these are used in the metaphyseal regions, either proximally or distally, and tend to be pre-contoured locking plates. However, there are certain situations in which a plate may be used in a diaphyseal fracture, including segmental fractures, those in which there is no medullary canal, and or if prior surgery with an implant is present. The majority of tibial shaft fractures are treated with reamed, locked, antegrade IM nails. Union rates are quite high, anywhere from 85 to 95%, depending on the type of injury treated. Malunion rates are low, infection rates are low in closed fractures. Expanding indications has allowed us to begin to use IM nails in virtually all tibia fractures, even those with articular surface involvement. Historically, metadiaphyseal and proximal third tibial shaft fractures have posed a problem for those using intramedullary nails for tibial shaft fractures. This is a multifocal problem, secondary to positioning and previous iterations of nail design. Much of the difficulty with nailing of proximal third tibial shaft fractures has been precluded with the use of the suprapatellar nailing technique, which is done in the semi-extended position, minimizing the amount of pull of the extensor mechanism and deforming force acting on the proximal segment. It's also easier to obtain intraoperative imaging. However, there is potential damage to the patellofemoral articulation due to excessive pressure of the instruments. Studies have demonstrated no difference in outcome or knee pain, and at this point is just another technique in intramedullary nailing of tibial shaft fractures. A major problem with tibial shaft fracture treatment is malalignment. This is a major complication seen with metadiaphyseal fractures. The deformity is usually valgus. Plating of the fibula has been helpful in reducing the amount of malalignment for metadiaphyseal fractures. The concept is that by aligning the fibula, there is an indirect alignment of the tibial shaft as well. Another technique to combat malalignment is the use of blocking screws. The concept being that the blocking screw will narrow the metaphyseal area to approximate that of the diaphysis. In general, the blocking screw should be always placed in the concavity of the deformity. Complications following operative treatment of tibial shaft fractures include malalignment, non-union, compartment syndrome, infection, anterior knee pain, and nerve injury, usually the peroneal nerve. Moving on to rotational ankle fractures, the common classifications include that of Weber and Czech, which is based on the level of the fibula fracture. A's are infrasyndesmotic, the B's are at the syndesmosis, and the C's are suprasyndesmotic. Lagi-Hansen described a rotational pattern of ankle fractures, which is most commonly used today. In addition, the AOOTA also utilizes a classification. In Lagi-Hansen, the supination external rotation is the most common. It begins anterolaterally and progresses around the ankle. The syndesmosis is involved in 50% of cases. It is important to identify when there is instability in the ankle. The most common way of doing this in a rotational pattern is by manual stress exam, demonstrated here. A slight external rotation stress is applied with the leg internally rotated 15 degrees under image intensification or fluoroscopy. The pronation external rotation injury begins medially at the medial malleolus and progresses circumferentially. It is denoted by a high fibular fracture, and the syndesmosis is almost always disrupted. The Mesoneuve Fracture, involving the proximal fibula and the medial malleolus, is a type of pronation external rotation injury. Supination adduction injuries involve avulsion of the lateral ligamentous complex or a transverse fibular fracture. There is a corresponding shear fracture of the medial malleolus, secondary to impaction of the talar dome, and the vertical fracture line exits the metaphyseal area of the distal tibia. There is almost always some form of articular impaction associated with these injuries. The pronation abduction injury is identified with a comminuted or transverse fibular fracture. These are highly associated with lateral dislocation, and there's often lateral articular impaction associated with these injuries. The fixation strategy involves beginning on the lateral side with restoration of fibular length. If the fibula is non-comminuted, a lag screw and neutralization plate is utilized. If the fibula is comminuted, a bridge plating technique is preferred. Assessment of reduction of the mortise is made under fluoroscopic control. Following this, the medial mal is fixed. This is the only opportunity to get a direct look at the articular surface of the distal tibia and talar dome. Often fragments need to be removed. The posterior malleolus is fixed based on a number of factors. Historically, size, anywhere from 25 to 33% of the joint, was a clear indication for repair of the posterior malleolar fragment. However, we've now come to know that syndesmotic stability can be restored with fixation of the posterior malleolus due to its connection with the posterior inferior tibiofibular ligament. In addition, any posterior malleolar fracture with a posterior dislocation should be considered for direct fixation of this fragment. This can be done either from posterior to anterior or with indirect reduction in anterior to posterior screws. The medial malleolus in isolation may be treated non-operatively if non-displaced. However, there are certain indications, including compromised skin, significant displacement, and ankle dislocation, that will require operative fixation. Following fixation of the malleoli, syndesmotic integrity should be assessed. This can be done intraoperatively with a Cotton's test or an intraoperative external rotation stress test. Any obvious medial clear space widening is an indication for syndesmotic fixation. The only way the talus can translate laterally in the face of an intact fibula or fixed fibula is with syndesmotic disruption. Note here a positive intraoperative stress exam with lateral talar translation. Rotational ankle fractures in diabetics is a special situation. Non-displaced fractures may be treated non-operatively with increased duration of immobilization in a cast with non-weight-bearing and serial radiographs for follow-up. Displaced ankle fractures in diabetics should be fixed, usually with stable internal fixation. However, consideration may be given to external fixation and limited internal fixation. These patients should be considered for prolonged immobilization and tight glucose control during healing. Complications seen with rotational ankle fractures include wound infection or slough, prominent hardware, post-traumatic arthrosis, neuroma, and rarely non-union. Pilon fractures refer to those fractures that involve the metadiaphyseal area of the distal tibia extending to the articular surface and are usually due to high-energy mechanisms, including impaction of the talus into the tibial plafond. They usually imply axial load and articular disruption. Modern pilons differ from the initial description by Rudy and Allgauer in the late 1960s, which were secondary to rotational mechanisms seen in skiers in the Swiss Alps. Pilon fractures are notoriously associated with poor soft tissue. An assessment of the soft tissue includes looking for abrasions, fracture blisters, contusions, compartment syndrome, and vascular injury. The classification is that of the OTA, the 4-3. Type A's are the extra-articular fractures, Type B's are the partial articular fractures, and the Type C's are the complete articular fractures, with the C3 being the worst prognosis. As far as treatment, non- or minimally displaced fractures may be treated non-operatively. Usually this is reserved for people with poor soft tissue envelopes or too sick to undergo surgery. Certainly open fractures, those associated with compartment syndrome, require urgent operative treatment, and use is usually done in a staged manner. Relative indications include joint incongruity of greater than 2 millimeters. Varus valgus or sagittal malalignment of greater than 10 degrees has also been indicated. The concept of temporary spanning external fixation originated with the Pilon fracture in the 1990s. The concept was to stabilize the fracture while allowing soft tissue swelling to diminish and resolve, and then in a delayed manner to go in and provide internal fixation to allow for articular restoration. During the delay, patients are treated with ice elevation and allows the surgeon time to preoperatively plan while the swelling resolves. Definitive fixation is usually performed at 10 to 14 days post-injury via a number of approaches. Historically, the Anthromedial approach has been the workhorse of repair of the Pilon fracture. It begins over the anterior tibialis compartment and curves anthromedially parallel to the anterior tibialis tendon. Historically, one has tried to maintain at least a 7 centimeter skin bridge between this incision and the incision for the fibula. However, newer plastic surgery literature has demonstrated that this may not be necessary. More recently, the interlateral approach to the distal tibia has come into fashion, indicated for lateral articular comminution or displaced Chaput fragment, or in the case of an open medial wound. Its advantages include the fact that a plate can be placed under good soft tissue coverage. However, the superficial perineal nerve is within the field and must be protected. Use of an external fixator definitively has been described as well. This is usually an articulating external fixator, although its popularity has diminished over time. The concept here is to distract the joint, get an indirect reduction, use limited incisions to disimpact articular segments, and use cannulated screws to fix the joint. The bridging external fixator is maintained for 2 to 3 months and allows for motion while the articular surface is healing. In comparison of ORAF versus external fixation with limited internal fixation, studies have demonstrated no differences at 1 year between groups, although in the external fixation groups there is more evidence of radiographic arthritic change. Early complications of Pilon fracture fixation include early wound breakdown, infection, and loss of reduction. Late complications include arthritis, malunion, and non-union. Salvage is tibiotalar arthrodesis. Moving on to the calcaneus, the goals of calcaneal fracture surgery includes restoration of calcaneal height, width, and length, restoration of the posterior facet of the calcaneus articular surface, restoration of the relationship of all 3 subtalar joint surfaces, and orientation of the tuberosity. The classic approach to the calcaneus is the extensile or L incision of Zwipp. It is based on the vascular flow of the lateral calcaneal artery. The flap must be kept thick, and minimal soft tissue handling should be maintained throughout the procedure to minimize traction on the flap itself. Even with excellent soft tissue handling, there is a 15 to 25% rate of soft tissue slough of this flap. It is important to understand fracture pattern, including the primary and secondary fracture lines. The primary fracture line is caused by the vertical nature of the talus acting on the sustentaculum, and the secondary fracture lines produce either a joint depression or a line exiting out the calcaneal tuberosity. For the Essex-Lopresti type of injury, This can be reduced using minimally invasive techniques and percutaneous fixation. Joint depression fractures are often more comminuted and require open reduction of the articular surface. Newer approaches, including the minimally invasive sinus tarsi approach, allows for a direct view of the articular surface and indirect reduction of the extra-articular portions of the calcaneus. Early reports have demonstrated lower soft tissue complication rates. Biggest complications with the treatment of calcaneus fractures that of post-traumatic arthritis and wound complications in 15 to 25%. Risk factors for wound complications in these patients include cigarette smokers, diabetes, and open injury. Subtalar arthrodesis is used either acutely or in a delayed manner. It is primary treatment for some Sanders type 4 fractures, and reports have demonstrated earlier return to work with the use of this management. It is also used in a delayed manner for those who develop painful arthrosis following calcaneus fracture. In these cases, often a bone block arthrodesis is used to restore calcaneal height. Moving on to talus fractures, also known as the aviator's astragalus, initially seen in early pilots who crash-landed their planes. The mechanism is thought to be a forced dorsiflexion of the foot following a fall from height. Nowadays seen mainly in motor vehicle crashes as the floor pan pushes up on the foot. Talus fractures are very rare and are less than 1.1% of all fractures seen. The majority of these are talar neck fractures, and that will form the majority of what I will discuss. Important to understand the blood supply to the talus, which include the artery of the tarsal sinus and tarsal canal, which are branches of the dorsalis pedis, and the artery that goes through the deltoid to the medial malleolus. The majority of the talus is covered in articular cartilage. Radiographically, basic foot trauma series, including apiolateral obliques of the foot, are obtained. The canale view, which is originally described for post-traumatic malunion, is an oblique view, which usually demonstrates talar neck varus. Nowadays, CT scan has replaced these specialized views. The classification is the Hawkins Classification. A Hawkins 1 is a non-displaced talar neck fracture. These can be treated non-operatively. They're often picked up spuriously when scans are obtained for other reasons. This can be treated non-operatively, again, with a low rate of avascular necrosis. The Hawkins 2 is the most common. This is a displaced talar neck fracture with an incongruous subtalar joint. Timing of fixation is not as critical as once thought, but should be done early within 24 hours. There's a 25 to 30% rate of AVN regardless. Hawkins 3 are displaced neck fracture with disrupted subtalar and tibiotalar joints. Here, the rate of avascular necrosis is greater than 50%. These require operative fixation as well. The Hawkins 4, which is the least common and was described by Canale, is the type 3 plus disruption of the talonavicular joint. There is a 75 to 100% rate of AVN. Approaches to the talus include the medial approach, which is made between the anterior and posterior tibial tendons, essentially straight down to the bone. Try to avoid stripping of the dorsal neck if one can. Often this is the site of most of the medial comminution. If the fracture extends proximally, a medial malleolar osteotomy can be made to preserve the deltoid blood supply. A medial malleolar osteotomy is also useful in a talar body and dome fracture. It is less extensile than the lateral approach. The anterolateral exposure is started at the tip of the fibula and extends toward the fourth metatarsal over the sinus tarsi. The EDB and perineals interval is developed down and opened into the sinus tarsi. There is some fat which is excised. Usually there's less comminution and a reed can be made easier on this side. This allows for dual fixation with screws or a plate on the lateral side as well. The posterior approach is often less used, but can be used in conjunction with either the medial or interlateral approach or both. A study from 20 years ago demonstrated that posterior to anterior placed screws were biomechanically a stronger construct than other constructs for fixation of talar necks. However, clinically that has never been borne out. The interval is the standard anterolateral interval between the FHL and perineal muscle bellies. A Hawkins sign is a positive sign seen usually at 6 to 8 weeks following talar fracture fixation. It is heralded by patchy subchondral osteopenia on the AP and mortise view, and its presence is a reliable indicator that the vascular supply to the bone has been maintained and that there is no AVN. However, its absence is not a reliable indicator of AVN. More important to compare side to side. Treatment of AVN of the talus depends upon whether or not there is collapse. There's no universally agreed upon protocol. Weight bearing is often limited. Patients often go on to develop post-traumatic arthrosis. However, sometimes tibio-talar fusion can be difficult following osteonecrosis of the talar dome. Moving on to Lisfranc injuries, there are these involve the tarsometatarsal joints. Some are obvious and some are subtle. They are usually secondary to axial injuries and heralded with plantar ecchymosis, and radiographs demonstrate either bony or ligamentous displacement. The key structure indicated is Lisfranc's ligament between the base of the medial cuneiform and second metatarsal, which help form the keystone. The classification is homolateral, isolated, or divergent. Oftentimes, these patients are diagnosed with pain, with ambulation, or on weight-bearing films. CTs or MRI can help elucidate subtle injuries. Outcomes have been demonstrated to improve with an anatomic reduction. Ligamentous injuries are worse than bony injuries, and fixation, if both columns are involved, require 2 incisions. The medial column is less flexible, and stiff, stable fixation in the form of screws is usually placed. Lateral column is more flexible, and temporary K-wires for 6 weeks are utilized in those cases. Meta-analyses of 3 articles which compared primary fusion to ORIF demonstrated no difference in outcome. However, more hardware removal was seen with ORIF, and no difference in patient revision surgery were reported. Complications include wound breakdown, superficial nerve injury, hardware breakage, persistent pain, and long-term arthritis. Often these patients require shoe orthotics to aid in mobilization and ambulation post-injury. Thank you very much.